Good day, everyone. My name is Mohammad Faeizi bin Rajab. So today for the workshop presentation, I would like to present on the case of effective endocarditis. So let's move on for the patient demographic. So our patient is Mr. JYP, Chinese and male with the age of 63 years old, with have a body weight of 78 kg and height of 160 cm. For the calculated BMI, our patient have 30.5 kg per meter squared, which indicate that our patient is actually obesity. So our patient was admitted to the hospital on the 22nd of June 2021. So for the family history, both of his parents has passed away and had history of hypertension and also diabetes. His brother had diabetes and his sister also had chronic kidney disease, CKD. So for the social history, our patient is an ex-smoker for past 20 years ago and has no history of alcoholic or drug abuse. Our patient mentioned that he has allergy to a painkiller, but he was not specified which type of painkiller because he was not remembered what type of the painkiller. So for the past medical history, our patient has history of hypertension, dyslipidemia, ischemic heart disease (IHD), and also undergo CABG with mitral valve replacement, bioprosthetic, plus LA appendage ligation in March 2021. So medication history review, our patient was received tablet Lasix, which is furosemide, tablet Lipitor, which is atorvastatin, tablet cardiprine, which is 100 mg aspirin together with 45 mg glycine, and lastly is tablet bisoprolol. For Lasix and bisoprolol, our patient will receive as the antihypertensive medication. For Lipitor is for antihyperlipidemia, and also for cardiprine is as a monotherapy of secondary prophylaxis for IHD. However, the dose and frequency was not confirmed as this patient was unable to remember those information regarding during the patient interview. So for the chief complaint, Mr. JYP was experiencing fever that was not improving and become more lethargic after being admitted to the hospital Sungai Bakap. So our patient was being referred to the HPP on the 22nd of June 2021. So for the history of presenting illness, as I mentioned, Mr. JYP was admitted to the hospital Sungai Bakap on 20 June 2021 after developing a high temperature, cough with sputum. So he was suspected with LRTI, and the empirical treatment for LRTI is IV ceftriaxone 1 gram OD on the hospital Sungai Bakap. So this patient was transferred to HPP on day 2 for the further management after the fever was not improving and become more lethargic. So regarding the compliance issue, Mr. JYP sometimes forgot to take his medication and he was not on the purpose for skip his medication. So he mentioned also that his wife will involve in his diet and also remind him about his medication schedule. So right now, Mr. JYP was having active diagnosis of effective endocarditis. So for the chronology of the case, for a review of system, our patient was ill-looking but still alert with a high blood pressure, which is 157 over 99 millimeter mercury, and high pulse rate, which is 110 beat per minute, and high body temperature, which is 38.9, with normal oxygen saturation, which is 98%. Our patient have clear lung and also soft and non-tender abdomen. Our patient have positive conjunctival petechiae for eye, and for the cardiovascular, our patient have positive murmur with mitral regurgitation, and the DEE suggests the presence of vegetation on the mitral valve. For the skin, our patient have a petechial lesion, genuine lesion, and also osler node, which is the sign for the endocarditis infection. And for the extremity, our patient have positive nerve clubbing and also splinter hemorrhage. For the daily progression, on the day 1, our patient was feverish and looked lethargic with a tachypneic with the oxygen saturation of 95%. The TEE showed the vegetation at the mitral valve. So the physician plan is to change from the ceftriaxone with IV unacin 1.5 gram TDF, IV amikacin 50 mg OD, and also IV gentamicin 60 mg TDS. And the physician also would like to add on tablet paracetamol 1000 mg QID and continue other medication, and the blood culture and sensitivity was being traced. On the day two, our patient was still looking lethargic, and the body temperature was still spiking and showed it has a spiking fever. The blood for culture and sensitivity was being sent for and TDM for amikacin and also gentamicin also was done. And the other medication was still continue, but the physician was key IV to add on amphotericin B if there was no improvement for this patient. On the day three, the fever was not improving. However, we will receive the blood culture and sensitivity. It showed that our patient have MRSA growth in his body. So straightly we change the antibiotic. The physician changed the antibiotic to vancomycin 750 mg stat BD, and other medication was continue. Other medication was continue. On the day four, the patient was look comfortable, but it still has on and off fever. So the physician plan was still continue with other medication, and TDM for vancomycin was sent. On the day five, patient was look comfortable. The fever was improving, but the serum creatinine keep increasing. So the physician was planned to continue with medication and do the TDM result for the vancomycin. On the day six, the patient was have no fever, and this patient was look comfortable. However, the serum creatinine was still high. Therefore, the physician was decided to reduce the IV vancomycin from 750 mg BD to 750 mg OD. For the graph and also lab data, firstly, we have total white blood cell count. So white blood cell can be a sign of infection. As we can see that our patient is actually having a high white blood cell during the admission to the hospital. And on the 24th of June, the value was getting improved, which is decreased as the vancomycin was given on the 24th of June 2021. So it was showed that the efficacy of the vancomycin treatment. Next is the body temperature. Body temperature also another sign for infection. As you can see from the 22, 23, and 24, the body temperature was still high, far from the normal range. Starting from the 25th of June, the body temperature was getting decreased to the normal range as the vancomycin therapy was done on 24th June. So for the blood pressure and heart rate, for the blood pressure, our patient was targeted is below than 130 80 millimeter mercury as our patient was diagnosed with IHD and also hypertension. So as you can see, the blood pressure was still above the targeted range, even though the furosemide and also bisoprolol was given to this patient for her hypertensive medication. On the other hand, for the heart rate, the targeted is below than 100. Our patient was recorded 108, 110 on the 2 day of admission, but it's getting improved as go on. It show improvement for our patient. Next is hemoglobin and also hematocrit level. So as you can see that hemoglobin and hematocrit was low in our patient, and this can be indicate that our patient is actually having anemia. So for the serum creatinine and creatinine clearance, our patient has a significant increase in the serum creatinine and also a decline in creatinine clearance, which show that our patient is actually having kidney impairment. This might be due to the antibiotic use in our patient, which is the aminoglycoside and also vancomycin. So for the management and treatment given for the infective endocarditis on the 22nd of June 2021 to 24 of June 2021, IV unacin 1.0 TDS, IV amikacin 50 mg OD, and also IV gentamicin was given to our patient. On the 24 to 27, the antibiotic was changed from dose 3 to IV vancomycin 750 mg stat BD as monotherapy, as our patient was shown for the positive culture for the MRSA and it was sensitive for vancomycin. So on the 27th of June 2021 and onward, the dose of vancomycin was reduced to 20 mg to 750 mg OD due to the high level of serum creatinine in our patient. For other treatment, on this patient was received cardiprine and also Lipitor, which is atorvastatin, furosemide, and also bisoprolol for his hypertension, dyslipidemia, and also IHD condition. For the pharmaceutical issue, firstly, we have inappropriate selection of antibiotic. So, according to the National Antibiotic Guideline, the empirical treatment for infective endocarditis in patients with prostatic valve less than 1 year, it should be vancomycin and also gentamicin. The use of unacin, gentamicin, and amikacin was not appropriate because this combination can increase the risk of nephrotoxicity and also ototoxicity, and it also can increase the risk of developing antimicrobial resistance in this patient. So for the pharmacist recommendation and plan, we suggest to initiate this patient with combination of vancomycin and also gentamicin as the empirical treatment for infective endocarditis in prostatic valve for less than 1 year. So this medication has broad spectrum for the coverage and also safer for this patient. So we have to monitor for the serum creatinine and creatinine clearance and also the hearing function, because this kind of monitoring can be given to check for the nephrotoxicity and also ototoxicity that being caused by the previous antibiotic. So the second one is the therapeutic application. Both gentamicin and amikacin was belong to the same group, which is aminoglycoside, and this medication was given as empirical treatment for infective endocarditis. So it can increase the risk of nephrotoxicity and also ototoxicity together with the risk of antimicrobial resistance. So for the intervention is we would like to remove the amikacin from the treatment and maintain the use of IV gentamicin with a dose of 200 mg OD. We also have to monitor for the nephrotoxicity and also ototoxicity. For the next is adverse drug reaction from the aminoglycoside and also vancomycin. According to the lab data, we can see that the patient kidney condition was impaired and can be seen from the decline in the creatinine clearance. So this condition can be happen from the use of aminoglycoside, which is amikacin and amikacin and also gentamicin, together with and vancomycin on the 24 to 27 as the post drug can cause nephrotoxicity. So since vancomycin is given as definite therapy, so the dose is suggested to be reduced from 750 mg PD to 750 mg OD. And we have to monitor for the serum concentration of vancomycin with the TDM. So for the next PCI is drug-drug interaction between furosemide and also aminoglycoside. So the use of aminoglycoside together with furosemide will increase the risk of nephrotoxicity and can be seen through the increased level of serum creatinine and also decline in creatinine clearance. So the intervention is we would like to withhold the furosemide until the therapy of aminoglycoside is complete. And we also have to monitor for the renal function through the electrolyte balance, creatinine clearance, and we have to check for hearing function by monitor for hearing loss. For the next PCI is untreated condition of low hemoglobin and also hematocrit. So as I mentioned, low hemoglobin and low hematocrit level in this patient will indicate that this patient is actually have experienced iron deficiency anemia. So the intervention is to monitor the hemoglobin and hematocrit level, and consider to start with the hematinic, which is consists of ferrous fumarate, folic acid, and also vitamin B complex if the hemoglobin level was still below the normal range. Next PCI is insufficient treatment for IHD. So patient who undergo CABG will receive dual antiplatelet therapy for up to 1 year as the secondary prophylaxis of cardiovascular disease. So the clopidogrel should be given for up to 1 year while the aspirin for a lifelong. So the intervention is to initiate the dual antiplatelet therapy by initiate the clopidogrel 300 mg following dose, and also continue with clopidogrel 75 mg OD for the patient as the maintenance dose. Next is high dose of bisoprolol. Bisoprolol was given to this patient as the treatment for his hypertension. So according to MINS, Malaysia, and also Lexicon, the maximum dose of bisoprolol for hypertension is 20 mg per day. So the dose adjustment for bisoprolol need to be done, and the recommended dose is 20 mg OD for this patient. Next is insufficient therapy for hypertension. The blood pressure of this patient was remain higher than targeted range, which is 130 80 millimeter mercury, although receiving bisoprolol and also furosemide. This showed that this patient had inadequate therapy for his hypertension. Therefore, we suggest to add tablet diltiazem 90 mg/d, which is the class of calcium channel blocker, as it is suitable for the patient that is diagnosed with ischemic heart disease and also comorbid with hypertension. Next is inappropriate use of furosemide. The usual drug that being used in patient that treated with beta blocker is thiazide. In addition, our patient also was not develop any sign of fluid retention. Therefore, we would like to change furosemide with hydrochlorothiazide 12.5 mg OD. Next is no data for lipid profile. Lipid profile is the very important lab data for us to assess the lipid level in our patient. So we would like to ask for the lab data for lipid profile from the physician in order so that we can improve and monitor the progressive of the hyperlipidemia in our patient. Next is the compliance issue. Um, JYP often miss or skip its dose. Therefore, we have to counsel the patient on the importance of compliance with medication and suggest ways to improve compliance, such as alarm for medication, timetable for medication, and also place the medication at a place that can easily be seen. On the other hand, we can also counsel the family member uh, of Mr. JYP to help him and aid him to improve his compliance with the medication. Lastly, the possible changes in the antimicrobial regimen. For infective endocarditis with prostatic valve with MRSA, as happened in our patient, rifampicin was recommended to be added with combination of vancomycin after 3 to 5 days of vancomycin therapy. So will help in providing sufficient eradication of bacteria and thus preventing the microbial resistance. Therefore, the recommendation is to add the tablet rifampicin 300 mg OD to the vancomycin therapy on the next day. So continue this therapy for at least 6 days in order to improve the bacterial eradication. That's all from me. Thank you.